this is enabling aligned action, multi-payer alignment strategies and impact. It builds seamlessly from what you've heard this morning from John Blum, Mark McClellan, and our CMS colleagues. I want to get a sense of who's in the room. Who here is from a provider group or health system? Raise it high and proud. Okay. What about from a health plan? And what about what I would call a purchaser, like government, purchaser, employer? Okay. Then there's some other people in here. We're gonna
got a couple consultants.
Yeah, okay. And then there's only two choices here. Do you think of yourself as working on the national level or the state level? Okay, so we know who our audience is here. Thank you for joining us. I'm Alice Chen, co-chair of the LAN's Executive Forum. I have to read my notes. I am Dr. Alice Chen, and the Chief Health Officer of Centene, and I'll be moderating this panel. And we have an incredible lineup, but because we have so much of a thought leadership bank here, I'm not going to actually introduce each person. I think we should have a slide up with people's names. No. All right, very briefly. That's okay. We're nimble here. So we have Kate Davidson, director of the Learning Diffusion Group at the Center for Medicaid and Medicaid Innovation, a wave. We have Dr. Renee McLaughlin, National Medical Director for Value-Based Relationships at Cigna. We have Alicia Berkmeyer, EVP and Chief Health Management Officer for Arkansas Blue Cross and Blue Shield. There we go. Danielle Lloyd, SVP, Private Market Innovations and Quality Initiatives for Clinical Affairs at AHIP. And then last but certainly not least, Dr. Judy Zerzenthul, CMO at the Washington State Healthcare Authority and my fellow LAN Executive Forum co-chair. And all of their bios are in that nifty app that I mentioned earlier. So let me just start by referencing back to some of the points you heard before. So we know that care happens in the provider's office, in the health system, in the community, right? You heard from John that more and more of the 3 M's, which is what CMS's purview, Medicare, Medicaid, Marketplace, is being administered through third-party groups like mine, health plans. And you heard Mina say that no provider, hopefully, is looking at the payer type when they're thinking about what to focus on. Should I be working on diabetes, hypertension, colorectal cancer screening? So recognizing that in this current healthcare ecosystem that we have, complex, multi-purchaser, multi-payer, market-driven system alignment is not easy or straightforward. And so that's really the context for how LAN is approaching this. It's about promoting directional alignment rather than really cookie cutter, like everyone has to do the same thing, because we know that's not going to be possible today. So the idea is directional alignment, balancing the desire for synergy with flexibility. So if you cue slide 1, under directional alignment, the idea is that payers align on core priority areas for payment arrangements. So this idea of convergent evolution, rather than saying, here's the same contract that everyone should be using across the board. Because truthfully, we are a very large country with different populations and different population health needs. So this idea of, here's the broad framework, here are the core areas we need to focus on, how do we move towards convergent evolution? And the goal is to identify foundational elements of agreement to iteratively build more specific alignment. Next slide. The LAN applies the Duke-Margolis multi-payer alignment framework in our efforts to advance multi-payer, multi-stakeholder alignment. And you see here that the pillars are really considered foundational. Performance measurement, health equity, data sharing, technical assistance. These are the areas that we think are ripe for payers, purchasers to come together and say, where within this realm do we think we can land on some high-level principles, goals, and then we start making it more granular, right? Because in the end, the truth is, providers would love it if it was just one system because they actually are not able to pivot to all these different multi-payer platforms. So I'm going to get started. We're going to be discussing how, from each of our panelists' perspectives, we're achieving alignment and collaboration across states, payers, providers, with a real focus on some of the pillars that you see here before you. Could each of you, and we are going to make this interactive, so the first round we are going to go down the line, but there's a lot of, just even in the green room, we were talking back and forth. Could you share a multi-payer alignment effort underway in your organization that's had the most impact and why? And what would you highlight in that context as some of the critical factors that facilitated successful alignment?
So I will get us kicked off. So it's so good to be here with you guys in person. The energy has been really just a lot of fun, and especially to be here on this panel today. So thanks, Alice and everyone. Last year we had a similar panel. We were talking about alignment efforts, and actually the Duke Margolis Center had just launched the multi-payer alignment framework at that time, I think. And we spent a lot of time talking about strategy and talking about what directional alignment will look like. And so as I was coming here today, I was so excited to say we have examples to point to, concrete examples of where we've really been executing against that strategy. And so Liz Fowler shared earlier a little bit about what we're thinking about from our primary care portfolio, and I thought I'd give a couple of examples of how we're thinking about taking the multi-payer alignment framework that Duke Margolis has laid out and really embedding that in the strategy for primary care. So Liz mentioned making care primary in the AHEAD model. I'm going to pan out a little bit further and just think about our entire portfolio of primary care models. Starting with MCP, which is our model that we announced in June. And as Liz said, we are trying to create an opportunity for small independent safety net providers to have an on-ramp into value-based care. Then going across the continuum, we have primary care first, or PCF. And that model is intended for primary care, advanced primary care practices that are taking on more and more risk. And then moving over to ACO REACH, which is the ACO model that we're testing to try to integrate health equity approaches into our ACO models. And then thinking about SSP, so Mina also mentioned that we're trying to think about how we could test new models under the SSP chassis. And then finally to the AHEAD model, which is a global budgets model, where we're trying to shift the utilization patterns away from inpatient care toward outpatient care. But what's fundamentally the same underneath all of those models is that we're thinking about testing the same care delivery model, right? We have an idea from the NASM report that came out in 2021 of what we anticipate care delivery to look like, but we don't know yet and we don't think that there is a cookie cutter example of what all payment should look like. And so the Innovation Center is really thinking about taking a portfolio approach to primary care. As we were developing the Making Care Primary model, which I think has the most publicly available information about what we mean by directional alignment, we really looked at what states were doing and what commercial payers were doing and what was happening in MA, and tried to be least disruptive in how we were designing that model, with the intention that if we could get the public sector, so Medicare fee-for-service and Medicaid aligned, that we could really bring along some of the regional payers work as well as the national plans as well. So again, very consistent with what you're seeing here, not cookie cutter in terms of payment. We know that folks are thinking differently based on their patient populations about what the payment needs to look like, but we are thinking about alignment around quality measures. We've adopted the Universal Foundation set and made a couple of nuanced changes to that where we think that we need to push the needle in sort of testing new measures. And then also trying to align around technical assistance and learning as well as data and infrastructure. So I said a lot. I will pause there.
Yeah. Actually, I was hoping to jump to Judy as a kind of continuation of the governmental, federal, state perspective.
Oh, sure.
And maybe how that even ties to some of the models that Kate was mentioning.
Yes. So I'm with the Washington State Healthcare Authority. We provide coverage for Medicaid, state employees, teachers, and retirees. So it's a broad swath, which is super fun. And in 2019, we started a multi-payer panel, partially modeled after some of the work I had done. I'm looking at you, Alicia and Renee, in the Comprehensive Primary Care Initiative and CPC Plus. So that multi-payer table, in my experience, was very helpful to move things along. And so we started one in 2019, recognizing that primary care in Washington State was in trouble. There had not been investment, there had not been sort of thinking about how to support this. As I'm sure isn't true in all your states, there's a lot of burnout. There's a lot of difficulties in providing primary care. And so we all came together around a common goal of how do we improve primary care and how do we make sure that primary care has behavioral health integration. And over a couple of years, we worked with a table of clinicians and health systems, and then also added in a purchaser or employer table to that to come up with a model that we thought we would work in Washington. Happily, it very nicely aligns with the Making Care Primary model, and so we are an MCP state now, and that is bringing Medicare to the table, which I think is only going to amplify our efforts more. And I think some of the things that have helped enable a successful multi-payer table at the state level include the common goal that I mentioned, include the state being the convener, because that helps with some antitrust pieces. Also the state being the convener because we hold contracts for a lot of health plans through those coverage that we do, so we can either wave a stick or a carrot at people to encourage them to come to the table. But I will say we've had plans that we don't have any contracts with be at the table, which I think is proof that this is very exciting and is the right direction to go. I think a neutral facilitator that can sort of talk with people behind the scenes and then bring summaries of folks' concerns, ideas together, and then being flexible and having a lot of conversation about what can work for all of us in terms of alignment. In our model, we have alignment in terms of expectations for clinicians and expectations for plans. We also have alignment for quality measures and for moving to a per member per month or capitated payment for primary care. And so I think it's moving the conversation in Washington State, and I'm hopeful that it's actually going to help primary care once Making Care Primary gets started, but we're very excited for that. And I think there's a long history, as others in the panel will share, of how multi-payer alignment can work.
Would love to go to Alicia, actually, just continuing the state Petri dish.
Absolutely. So I think that when I thought about this question, many things ran through my head of the things that we do that are exciting in Arkansas. But then I narrowed it down to really kind of a foundation, and that foundation has been collaboration and commitment, and really making sure that we have the right stakeholders at the table. And through that, through the common goal of really improving healthcare and also reducing that burden being our primary goal and focus of all the work that we do, we've been able to have some great accomplishments, really looking at quality measure alignment throughout all of our programs and any focus, be it Medicaid, Arkansas Blue Cross, or other payers in our state. We've really tried to align those measures and work through that. We also, it's been very important from the beginning, I think we started reporting those measures to the practices on Excel spreadsheets. So over time, we've been able to take that information, bring it to our health information exchange, share, and having that available and information more timely and accurate to the providers to be more actionable information for them. We recently, over the last couple of years, have been able to bring some of the large self-funded employers, and that's been an area that's been very beneficial to those hospitals and providers to have them at the table as well. Certainly through these stakeholder collaborations and information, having the patient voice at the table has been important. Probably one of the things I'm most proud of as a state that we have done is the development of a nonprofit organization, Arkansas Behavioral Health Integrated Network, which is a focus on behavioral health training and integration into primary care. We all know that you can't treat the person without sometimes the behavioral and physical health being addressed at the same time. And so what that organization does is really to help train and educate that merger of primary care into behavioral health and that collaboration, work with even universities across our state to start bringing some additional students and care into that. The final thing that's been important is in the technical assistance is really coming together as a state, and in some cases we've even partnered with Oklahoma and Missouri and Kansas City as well, on how do we train the people that are out in the field to help the practices in this transformation work. Those are things that come to my highlights, that are thoughts, but really it's trust, engagement, relationships, and getting that commitment to align in that common goal.
Yeah, well said, and a lot of what's reflected in the video that we saw this morning. Alicia, wondering, when you go from a state level, as large as that is, to the national scope, how do you continue that trust? I'm sorry, I'm looking at Renee, who's puzzled, saying, as I say, Alicia.
I was going to come up with an answer for you, Alice.
It's like, but as you go to more of a national scope, how do these relationships and this trust play out?
Yeah, so when y'all asked me to participate in this panel on multi-payer alignment, I thought, what's harder, the fee-for-service to fee-for-value transformation or multi-payer alignment? And they're both really hard. But as I'm listening to my co-panelists here talking, there are a lot of similarities in what we've identified as enablers or facilitators. My experience in multi-payer collaboration is at the state level as a commercial plan. It's now been 8 or 9 years since we started the state transformation work in Tennessee, which really has been quite successful. And one of the commonalities, particularly Judy, what I heard you say, is having a third-party convener. And that was really, I think, critical in standing up a functional multi-payer collaborative. And in this case, there was a third-party convener, but the state was the sponsoring organization. And that was really helpful. And it also was helpful that the state was also a large client of Cigna at the time. So you got our attention in multiple ways. So I think those are a couple really key requirements. Third-party convener, having the state at the table in one way or another. I think the other really key enabler, and Alice, when you asked the question for who out in the audience were providers, and some hands went up, not a lot. That really is critical in any multi-payer collaboration. It's not about we're doing this to you as providers, we're doing it with you. So having providers at the table to really be part of the sausage making early on. So just a couple thoughts.
Yeah,
but a lot of commonalities, I think.
And then wrapping up with Danielle, from your perch at AHIP, looking across plans, large and small, regional, national, what among your colleague comments has resonated in terms of what's worked, facilitators, and then we'll probably segue into the flip side of what are some of the remaining challenges.
Yeah, so I think what I would share, in addition to my sort of regular duties at AHIP, I'm also the steering committee chair of something called the Core Quality Measure Collaborative, and that is a public-private partnership founded in 2015 between AHIP and CMS. It's now housed at Battelle, and it's comprised of around 75 organizations from specialty societies, plans, consumer groups, employer groups, regional collaboratives, et cetera, which I think is part of the value, right, that it's such a broad group of organizations. And its central goal is to align quality measures across public and private payers within the context of value-based payment programs. We do this to try to improve health outcomes, certainly to reduce burden, another common theme across the group, by identifying these core sets of high-value, evidence-based quality measures for use within these programs. Certainly, we are also trying to move to a point where consumers can have a consistent idea of what is good, right? That there's not, 1,000 different measures being used across the providers, and to support the accountability aspects of these value-based programs. We do have 10 core sets that are up publicly available on the website It focuses on ambulatory measures, although it does have some hospital and other types of measures. I'm not going to list the 10 areas. I'll probably forget one if I try that, but I urge you to go take a look at the website. And one of the other things we're looking at is not just aligning around the specific measures, but what we're calling the measure model. I think people are, very familiar when you say payment model, that there are many steps in that, from attribution to benchmarking, et cetera. But, in terms of the quality component, trying to see if we can align not just on the measure, but how it's collected in the EHR, how it's aggregated and calculated and reported, and all of these things. So that's sort of the next step in terms of adoption and work. But we know that it's relied upon by payers. We have about 70% of the covered lives in the country participating in this. It's often referenced in the literature. CMS referenced it in its Universal Foundation New England Journal of Medicine article, and the two are very much aligned where it makes sense. The Surgeon General has mentioned it in advisories on building a thriving workforce, et cetera. So we're really proud of the work that we've done through this not just multi-payer, but multi-stakeholder collaborative nationwide.
I can think of a couple of other, I think, facilitators that I'm curious to see what my co-panelists think. One is that as we represent plans, we can each think of the coolest model ever, but if we are just a small part of a practice's payer mix, they aren't going to care that we have the best model ever. And so I think doing things in a multi-payer way really amplifies the ability for payers to push towards system transformation and push towards value-based care. And it super helps clinicians because they don't have to chase all of these quality measures. They don't have to, it provides some administrative simplification. And then the second thing that I have found to be useful, particularly in CPCI, but starting to use it some in Washington, is this idea of peer pressure. That, I could go back to my organization and say, hey, Alicia's able to do this. Like, why can't we do that? And so I wonder if you guys would sort of think about that as well, or if there's other things that you can think of.
I agree with that completely, Judy. I actually was told by practices when we did our early days, and the reason why we fell into CPC Classic is the practice sitting out there going, hey, this is great, you're doing this, but you're just 20% of my practice, and so I can't do it for everyone. The other thing that aligns with that we continue to hear is because of those 8-point spreadsheets and the measures and metrics, practices are actually having to choose, okay, where can I get the biggest bang over my buck here? And I'm going to have to focus on these programs and not these programs. And so that alignment's so critical, because if we don't, we're going to have so many silos that we're not going to get where we're trying to go.
Yeah, to that end, I think an important part also is, to the extent that we start getting to multi-payer reporting of some of the measures, that does get us past this challenge of having small numbers problems. That can be for specialty measures. As we move to stratification for equity, we run into the small numbers. So to the extent that we're able to start putting some of that information together, the measurement is going to be more stable, the benchmarks are going to be more stable, et cetera.
Great point.
One more thing to think about with that is who's doing the aligning. And what I mean by that is if we as payers all agree and align on whatever it be, a core measure set or what have you, and then we foist it upon providers. That's us aligning, not the providers. Versus taking a flexible approach where we align on a broad set and then allow providers to choose what's important to them, to their population, so they do the alignment internally in what's relevant to their own practices. So building in that flexibility back in the spirit of doing it with, not to.
I think that's particularly true for like pediatricians or, versus internal medicine or versus family medicine. When you have different populations, different quality measures, different sort of ways of care and delivering care is going to be different. And so you'll want to be able to be a bit flexible in those pieces. I think, Kate, one of the pieces that we've been chatting with CMMI about in the Making Care Primary is that The measures right now are all Medicare because that's where they're starting. And so how do we have alignment for the pediatric folks? How do we have alignment for women's health and younger populations? More of the behavioral health and substance use needs of the Medicaid population. How do we sort of cross that and allow practices to be flexible or pick what's most important to their population?
Yeah, and definitely a both and. I mean, as we think about what is the purpose of all of our organizations, if it is to drive population health, there are places where having that synergy and just, that 8-point find document that I had sent over to CCSQ, in the 150 measures across the 3 M's, Medicare, Marketplace, and Medicaid, there were 4 measures, aside from CAPS, which I don't know if there are any proponents here of CAPS, but I personally think we need a replacement. But of the other clinical measures, 4 were common across all. Now, obviously, like again, for adult measures. And so how do we think about the both and, where we need flexibility and where we actually just decide to do the same thing so that it cuts through all the noise? Because just as moderator's prerogative, part of the way I came to this work was when I was at Covered California. Covered California contracts with a dozen plans. And what I realized was even though Covered California was the largest state-based exchange, it was only a small portion of each of the plans covered lives. But then so we were one of the purchasers, CalPERS was another, a bunch of employers, right? So we all had different priorities and measures. And then each of the health plans turned around and contracted with the same providers. But they each then had their flavor, which was an iteration of the purchaser's desires, right? So you have these voltage drops of intents. Like even though we all want to do population health, we all want to actually tackle the big things like cardiovascular mortality and cancer, it ends up being very diffuse and fragmented. So what I'm hearing as the bright spots are having a point of view around your delivery system. And again, full disclosure, I'm a primary care doc, just like Judy. And so, we're a little biased, but the evidence says that a healthcare delivery system that's predicated on robust primary care actually does better from a value perspective, right? As defined quality over cost. That having a state or neutral convener is a way to bring everyone to the table. Behavioral health integration has popped up in a number of places just because, particularly post-pandemic, we know that really colors, infuses, accelerates good if you can get coverage and bad if you can't access behavioral health services in terms of outcomes and cost. Multi-stakeholder perspectives, not just being the people on this panel, but providers, importantly, employers, patients, researchers. And we talked a lot about quality, which in some ways, when you look at the pillars, it seems like the lowest hanging fruit, and yet, that 8-point font spreadsheet persists. So thinking back, those are some of the high points. Talk to us a little bit about where the challenge, there are many, many challenges, but if there's one thing that you would have a call to action to this group in terms of what we should do in order to move the dial from where you sit, what would it be?
Yeah, right. So I think, number one, as I was thinking about today in this panel, there's examples from every single person on this panel where I personally have been engaged in multi-payer alignment efforts, which is really cool. But a couple of things come to mind. Number one, I think about, Judy, what you were talking about with the convening work in Washington and how when we started to approach Washington about, hey, what would it look like to test a Make Care primary model in Washington, bringing Medicare to the table at a convening that was already set with relationships that were already very trusting, made all of the difference. And I think that as I think about the work that we do, and we get from a local level where relationships are at the heart of everything that we do, right? It's about the heart of the relationship between the patient, their caregiver, and their clinician and their care teams, relationships between the practices and payers, to your point, Renee, but also relationships between payers. And so that's so important at the state level. I think about being welcomed into Arkansas last year when I came to visit, and this enthusiasm from the providers as well as the payers and the employers, and how exciting that was. Everybody on the same page thinking about their specific community and their specific patient populations. But it gets a little harder when you get to the national level. And I guess that's kind of where I'm going with this. You know, Danielle and her team at AHIP have been so helpful to CMS as we think about new payers, of being able to set a table for us to learn from other payers about what their strategic priorities are. And Renee and others, I think of Jessica Bartell at United, who've been so instrumental in helping us think through what would a national plan work group look like, which is what the LAN has been able to set. And so I think for the first time in a long time, we have the strategic initiative that has a neutral convener through the LAN that is inviting national plans to the table to think through some of the sticky wickets around where do we align, where do we not align, why, what are our strategic priorities. And we know that it's going to take, years to really get ourselves moving in the same direction. And I think it requires leadership at the end of the day. So we've got the table now. We know that it takes longer to partner, to execute against our goals. It's really easy to go it alone and to be able to go really fast. It's a lot harder when we start to think about some of the operational elements that are required in order to do some of those alignment efforts and some of those investments in resources. And so just so appreciative of the folks here today and your leadership, because I think that we've got so many bright spots that are happening at the local and national, regional level. And so to be able to sit here and say we're committed to taking action at the national level to align with some of those regional efforts is I think, really important.
Yeah, I just build on what you just said, and I think fundamentally we haven't yet, while we're kind of talking to it, but we have not agreed yet on what to align. And conversely, what not to align. I think it's important that when we talk about multi-payer alignment, we're not building a monolith that edges out innovation and variety. It may be the smallest payer that comes to the table with a model that's actually the right model. And if we had aligned them out of the room, we would not have had that innovation. So let's keep the door open for innovation, but agree where we really do need a common platform, whether it be on the quality measures, how we employ the quality measures, how we pay for quality within models. We might talk about it with time remaining, but how do we keep from having this conversation next year? But we did have this conversation last year and the year before and the year before. So,
And actually, because of our time, if you have a thought on how we prevent ourselves from having the same conversation, throw that in there.
Yeah, something I've already mentioned. Let's at the very least get more providers in the room. Let's see more hands come up. There are a lot of great organizations out there, not to plug anyone in particular, but bring the ACO organizations to the table as well, and let's have a multi-stakeholder conversation. And then just prioritize where we can do it, where we're going to do it, and let's stop talking.
And I can build off of that for the challenge that I perceive that as we work with the practices as well as hospital systems, we all talk in this room about how we need to reduce fee-for-service and increase value-based payment. I think of this from a perspective on a scale, and today we still have fee-for-service reimbursement to providers here and values here. And so we've got to start bringing the level a little bit down, and I think when we all kind of work towards that together, because they're living, what's the old saying, you've got a foot in each canoe, and as long as you keep in each canoe, but we've got to really balance that out and kind of support more value work. And that's one of the things we really are working on is how do we increase those dollars in the value, recognizing surely we'll have to have some fee for service still, but working through that. And then I think, so we're not here again next year. To me, as we talk so much for all of us around quality, and there are similarities in some of the quality work, how do we look at the data, put a spotlight on some of those quality opportunities, and do some quality sprints or some exercises and opportunities collaboratively, so we're sitting here telling a really good story next year. That's wonderful.
Yeah, not to stick with the negative here for a second, but I think one thing just to highlight from this, right, is that we still have to be super mindful of antitrust law. So we don't get to all agree on what we're going to do or not do, right? We have to make sure that each organization is making their own decisions and put things out for voluntary alignment and adoption. So I think that's an important grounding, because that's part of why it's really important when CMS or the states or others, and we have third parties aligning, that makes it a lot easier from an antitrust perspective. But a couple specific things, I'd say one is in the area of equity. You know, we did some work with the CQMC where we looked at our core measures and sets and said, okay, of these clinical measures, which ones should we stratify for different demographic factors? And we did that, and then the plan said, well, this is really nice, but it's not, the stratification's not built into the measures. So we're all about to go back out and do this in a different way. That's going to lead to different results. And so that's actually something we're going to be working on in the next year, is some guidance around that. And certainly AHIP has been working for 3 years on modernized demographic data standards. So not just race, ethnicity, but sexual orientation, gender identity, disability, veteran status, military status, foreign military status, you know, et cetera, right? Very long list. You know, part of it to make it more culturally sensitive to today, part of it making it a little bit more granular, so that we can get to the populations that we need to. And we're about to embark on some work that will be with the CQMC folks, but also we'll be inviting others to participate in terms of getting sort of broader vetting of these demographic data standards and then converting them to FHIR resources. And I mean, you know, FHIR, not FIRE, which I think most of you know at this point. But, you know, we really think you have to have that standardized data so we can try to collect once and use many times and not every single one of us be asking over and over and over again. But the other thing I'll just quickly say is we've been doing some work in partnership with the American Medical Association and the National Association of ACOs. And we put out a playbook recently called The Future of Value, with essentially the first chapter of it being on data sharing. And so, you know, again, best practices for voluntary adoption, but you know, it noted some challenges, right? We do still have a lack of mature data standards in a lot of areas, particularly in the quality measurement space. There are key infrastructure pieces that are lacking. So for example, you know, if we want to share data between payers and providers, how do we electronically find each other, right? You need to have a directory of the digital endpoints that we don't have today, because you can't call up friends at 5,000 hospitals and say, hey, how do I find you? And then certainly just, you know, from a capacity and capability perspective, everybody's starting at a different place. So how do we think about, are there different sort of versions of it, whether it's more pre-canned reports for some versus, you know, massive claims dumps for others, right? Thinking about what are the different ways we can get the information out there to meet different providers where they are. So that a lot of that's up there on the website. It's not that it solves every problem in the world, but at least it puts out some of the best practices so that we can sort of be, you know, trying to move in similar directions, right? This directional alignment.
So my difficulty is I'm going to +1 your data. That was going to be mine, because it is very hard. And I think particularly for practices in health systems, like how do you understand what your whole population looks like? When I did more full-time primary care, you know, I thought I was awesome at things, but all my data came to me in little bits of like, here's your 10 diabetics from this plan, here's your 40 people from this plan, and the ability to pull that all together to be able to see how you're really doing and across plans and get your plans to engage to help you, I think is really important. I guess the other challenge, I think, and this has been mentioned too, is how do we work together to provide practice transformation efforts? Many practices, certainly there are some in Washington State, are like, VBP, what's that? We heard that this morning of like, I don't even know what you're talking about. And so how do we work together to help get people to those places and get to an understanding of VBP and why it is so important for the health of their patients and to improve patient care? That's what we all want. Like, really, at the end of the day, this is about people and making them healthier and making them more functional and able to do their lives. And so that's what we want. I think in terms of action, we just have to do it. We just have to hold hands and say, we're gonna make a change in this area by next year. I think with COVID, we proved we can move fast if we want to. Like, we all turned on telehealth capabilities in, I don't know, a month, 2 months. Like, we've been talking about telehealth forever, or what seems like forever. And so I think if we pick something very focused, whether that's quality, whether that's data, whether that's we're all going to move to some kind of prospective payment for primary care or bundles for specialty or e-consults, we just have to pick something and do it. And so I think that's what's going to be different for us for next year at this time. We will have picked something and made some progress. And that's my
Someone
hope.
write that down.
Let's support Judy. Yes.
I think the only thing that I would add is, we met, a number of the plans met this morning at 8:30 in the morning, which thank you to those who came from the West Coast and were committed to being there, and that shows the commitment. But I think the conversation that we had was everybody has different levers, right? And I think that my question or ask or call to action is for all of the plans out there, for all of us to say what are those levers and identify them. You can hear that actually we're very consistent on some of the goals that we've set, and we're even consistent on the areas where we need to find alignment. But we've got to go back and do the homework around what are the levers that we have at our disposal in order to make that alignment happen. And so I guess I'm asking each of you, if you are from a plan out there, to do some of that work. I think that you've got a commitment from the folks up here, from all of us, that we're committed to doing that for the next year and beyond.
And beyond, because we know it won't be done
We'll-
here.
no.
We will have made progress, but that is a perfect segue for the word that started to coalesce in my mind as I was hearing the entire panel talk for health plans, which is collaboration, which really is, Danielle, you mentioned there's antitrust issues, and absolutely we need to be cognizant of that. There's fierce competition, and as you heard, we all have the same fundamental goals, and part of it probably for me comes from being in the Medicaid space. Centene's primarily focused on Medicaid. Our Medicaid agencies, we compete fiercely for that RFP, and when it's done, they say, okay, we want you to work together. This is a population health play. You have to coordinate. We expect you to actually come together, focus on behavioral health, maternal child health. And so I think that is a model where we could think about, we each have our own capabilities and our own strategies. Frankly, my own opinion is ideas are a dime a dozen. There are lots of smart people in this world. There are lots of people in this world. And so it really is about implementation and execution, right? So honestly, I think free-flowing sharing of ideas and data is actually where we need to be. If I could propose that we choose that one thing, I think quality and equity. And for me, equity is part of quality. If we could actually really decide to land on that, make some progress on that, because again, we can't move value-based care without those quality measures, because value is quality over cost. So that would be my proposal. If we had a little voting mechanism, we could see if people agree. I want to just wrap up before thanking the panelists with a PSA. So did everyone, who downloaded the little app? Okay, not that many people. There is also a web link, but all the resources are there, and I just want to call out the Land Multi-Payer Alignment Blueprint, which highlights much of the work that the STC states have done in terms of creating this multi-payer, multi-stakeholder movement. A lot of the things that you heard mentioned on this panel, you can get the details in that publication. Again, steal shamelessly, share seamlessly, right? That is the motto of population health and improvement. And with that, I would ask you that you join me in thanking our panelists.